So first, it's breaking down barriers, empowering advocates to strengthen patient communication. Another very nice session. And I'm going to ask back to the stage Dr. Ben Kennedy and Jennifer Wilson. As you no doubt could see, oh, here, Jennifer, do you need help? As you could see from earlier discussion, these two are very patient-centric, very passionate about the patient. So look forward to this. And Ben, I'm going to ask you to start if you can.
Okay, thank you. So obviously not quite as exciting as the next session, but here here we are. I don't need this, do I? Well, maybe we can do it just sitting down. I don't know.
So, do you have slides on this?
No.
If you don't have slides, just come in front of the stage. Bring your chairs to the front. And you can sit down by all means.
I guess I'm kicking off, am I? Or? We'd like to bounce off each other a little bit if we can, but I don't know whether that's actually going to happen or not, because it kind of depends. So we've been focusing and I've got some notes for myself, so you'll have to forgive me, okay, please. We've been focusing on that catastrophic, pivotal moment when our patients require treatment. But we know that a lot of people don't need treatment. And almost always from the time of diagnosis, there is a significant period of time before someone does need treatment. So let's talk about trust, because when we're building trust at the time of making a shared decision, choosing one of the therapies, that trust has to be there from the outset. So it's not something that we can suddenly factor in at a time of crisis when we're talking about what are we going to do about this awful disease that now needs to be treated. That trust and that relationship already has to be there. So trust being that beautiful, intricate, and fragile thing that it is, it's difficult to build and very easy, like a crystal, to smash. So I think it's worth just exploring it, and I hope to be able to come on to some more specific things as well. But just thinking generally, trust is based on truthfulness and faithfulness to our patients. And there are many elements to truth and faith. One of those is openness. So when somebody's sitting in front of me, that I'm able to say it as it is, but also to signpost it and say, are you ready to talk about your leukemia? To be open about using those words, leukemia, cancer. Signpost the conversation around, well, we need to talk about the results of the tests that you've had. We need to talk about what to look out for in the future. We need to talk about the nature of treatment in the future. All these things that will come up in conversation during potentially even that first consultation. You're covering so much ground. Acknowledging uncertainty is a hard thing to understand. Human uncertainty is a great challenge to us psychologically. And I think moving into changing some of the language that we have around that early phase of active monitoring is far more helpful than speaking of watching and waiting, which somehow seems to magnify that anxiety. So we've dropped that. Can we anticipate questions that our patients will have? When somebody's sitting in front of me, rather than sitting there passively waiting for something to arise in the conversation, oh, doctor, could you tell me something? You know, what do I look out for? It doesn't need to be drawn from me. Why don't we just say in the consultation, I'm going to explain to you the kind of things that perhaps would be helpful for you to know, to look out for, so that you can come back to me if you're worried about these things, whether it's infections, lymph nodes, symptoms of anemia, it could be any number of things. We need to discuss the triggers for treatment as well. So there are going to be technical words. And I say technical words rather than jargon, because I don't think we can avoid technicalities. There are things that mean specific things in medicine and in life and everything else. So we do need to use those words sometimes, but not gratuitously. They have to be in context. Otherwise, technical language turns into jargon. And jargon is not helpful. I think things can often be expressed in clearer ways. We have to maybe practice and reflect how we're going to explain things and perhaps help unpack those technical words when we're sitting down in front of somebody. So instead of saying, your immune system will be compromised, you know, who knows what that means? Nobody in their right mind walking off the street is going to know what your immune system is compromised means. Might mean everything to me, but I need to phrase that in a certain way. Otherwise, it's pure jargon. So I think this is something that we, you know, could be called health literacy. It's picking up phrases and understanding them. And there is an opportunity for us as clinicians in the consultation to check understanding about what those words mean and what they are. And we need to signpost to those high quality, reliable, trustworthy sources of information. Creating mutuality. It's on my notes, so I have to say it. And I think this is something around delegating responsibilities. And my patients understanding the impact of their health, of the disease on them, but being armed with the knowledge of what to look out for. So they know how to look out for themselves and know when to seek help appropriately. And I think it's not beyond our abilities to tell people clearly what it is that we might be worried about from my point of view. So what to look out for is really important. So we're there, sitting there talking about all this stuff, and I'm monologuing, and I think I'm giving out loads of really useful information. But how much is too much? Do I know what my patients really want to know? Jennifer, you're nodding your head there. It's time, for you to...
Because then they're calling me afterwards to say, well, you know, what do you think? And I said, well, what did your doctor say? Because if so... Can you hear me now? Better? Oh, good. So if they have an appointment with Dr. Kennedy or Ben, then they might get anxious. They don't know exactly what to do with this. And then they call, let's say, me. And I always say, well, what did your doctor say to you? What did you hear? I try to make sure that when anyone calls us, that I listen first, because sometimes it may not immediately be that conversation. It may be that conversation secondary to the fact that they're about to be evicted. Or, so I really go into each call open, listening, and then I hear what they were told, and then I try to sort of untangle what are the rubbing points that they're not sure of or they have questions about. I try to have them identify who their team is, because I'm assuming it's not just you, right? I mean,
Absolutely. I mean, so, there's the whole multidisciplinary team.
Sure.
There's the nurse specialist. There's my consultant colleagues.
Mm-hmm.
You might see Dr. So-and-so next time round. There's my team of registrars, the hematologists in training, really very good, very dynamic. They may not have the same experience, but you will get to see them, and they have a role to play in your care.
right. And we want people to feel comfortable using the team. But I mean, I always think it's quite helpful if people really think in advance, okay, what do I need to know? I'm going to the doctor next week, and, 5,000 questions are swirling around in my head, and I just don't know quite what it is that I need to bring to that appointment. I always say, have the players. So if you have a spouse, if it's yourself, have one notebook. Everything gets written down there. And then the day before you have this appointment, you may have a call. And you might have some adult children who want to weigh in, or you might have a really close friend who sometimes goes to the appointments with you. And I say, come up with the top 5 or 6 questions that you need answered at that appointment. Because if you don't, you walk in, you have a lot of very important information to convey, and the conversation takes on a life of its own. And then your doctor's standing up, saying goodbye, and that's it. So if you've handed the written out list of 5 or 6 questions to the doctor at the beginning, then what would you do with that? Like, how would that go for you?
I think we've got a fighting chance of beginning to address the important things that our patients might feel embarrassed to ask about, that we don't automatically address. Doctor, am I going to die? Do I have to give up my work? What's going to happen to my family? There are things that we don't necessarily address, but there is an opportunity for us to reflect from those experiences we have of meeting people, what is important to them. And if we can't come up with that list, at least provide that space to say, what is it that's really worrying you? What's the biggest worry on your mind?
Yeah.
And we could be surprised by that, I guess.
Right.
Because you're getting those questions.
Yes.
And it's not a great testimony to us that we're not getting them. So how are we blocking that? How are we closing it down? Because a consultation is not meant to be a safe space for us. It's meant to be a safe space for our patients to enter and feel that they are being valued and trusted and respected, to open up to us. How do we empower that rather than block it off and close it?
Right. And I really think, just, first of all, I'm a big proponent of just the warmth and really making people feel as though I truly care about them and I want the best for them. And I think once you sort of get that trust that you spoke about and the warmth, then they feel like, all right, maybe it's okay that I asked this even though I feel like it's dumb. Maybe I feel like it's okay to point out that I have this vulnerability, or I can't read, or I can't, the language you're speaking isn't the same language that they, as their primary language. And then you start to have a more real conversation about what it is that will help people. That's my thought.
So I guess, how much time have we got?
Yeah, we don't know.
A little bit of time, great. So we've been talking about, in many ways, active listening. And, on paper, we kind of know what those skills are meant to be, about maintaining eye contact and giving people the time and the space to speak to us openly, to check understanding. Have you understood what I mean about whatever it might be, some element of technical word, language, blood counts, what a lymph gland is, what a leukemia is, all these sorts of things that we can explore. It doesn't have to be done in one consultation. And we can talk about the limitations of time as well, and the value of our time, and not just the person in front of me, but 3 or 4 people down the line still waiting in the car, in the waiting area, who may not get to see me for another couple of hours if I spend an hour or so with this patient. Right. Then how do we efficiently answer the questions and impart information and work together? So that's a real problem that we face with active listening. But I think if we do that effectively, we can check understanding. We can reflect things back. We can also, I think, listen to a couple of other things. Symptoms. Okay. If we want to maintain trust, then I am not experiencing the symptoms that my patient is experiencing, and I do not know how important this is for them. Even if we cannot fully explain it, or if there is no easily accessible treatment for it, it's very easy to dismiss it. And if we dismiss our patient's symptoms, what happens to that trust? It's very fragile. So yes, your fatigue is very likely to be related to your CLL. I understand this is a major problem for many people. It's not something we understand very well. Some people find that exercise and maintaining your strength is helpful in your fight against that fatigue, for example.
Absolutely. But the other thing I'll say is that sometimes we get calls where someone says, oh, well, I'm not going to tell my doctor this. And while my head feels like it could blow up when I hear that, because I'm like, you're not going to tell the doctor that you're having night sweats because they might want you to start treatment? No. You must have this partnership. It truly is about the trust and the partnering with your doctor so that they can help you have the best life possible. And so I really want that for everybody.
There's,
Oh, no.
oh, no, there's more. There's more. Physical examination. So I don't know how much weight people would put on that, but I think this is something that is very easy to miss. And the value of a physical examination, if there are any clinicians in the room, this is something that's really important. So not only do we get to understand the contours of our patient's physical limits, but there is something that passes between us in terms of understanding that goes beyond words as well, that builds that trust as well as having an accurate. My doctor understood me. He examined me.
He cared enough.
Yeah.
I mean, is really how people see it. They say, well, I haven't had my lymph nodes touched or examined in years. And they say, I think it's bigger. So it really does go back to your just, it really means something when you take the time, even if it's briefly, to just see the spleen size or the nose. Like, all of that matters. And it conveys a lot more than just
Yeah,
the exam.
I think this is true. It's important for us to lay out next steps if we're in a consultation. What's going to happen next? We don't have to cover everything in one go. There will be things that may not be appropriate to talk about during that very first consultation or the second consultation, but things like, what is the nature of these prognostic tests? What does it all mean? And what does genetics mean? And all those things that's not terribly human, but it could be very relevant. So I think those are things we can prioritize how we parcel up information rather than trying to cover it all in one great big splurge, which is just going to be confusing. So
I think we will,
I think
I think a patient would be
shoving
well
hold.
served to have this hematologist and this patient advocate working on their behalf. Thank you very much. One question, is there one question out there? I see a hand back there. Who has the mics? Who has the mic?
John, you always ask difficult questions, so you can have my microphone, so I can't answer it.
The difficult patient, and this is a masterclass in patient communication, and it's brilliant, the stuff that's coming out. But the difficult patient, and I'm speaking from first-hand experience, not so much from an advocate, but from just a personal friend who has been diagnosed with CLL, just simply wants the doctor to decide what treatment they need and when, and doesn't want to delve into the information that's available, doesn't want to talk to anybody. They know what I do, but we've never had a conversation, and I fully respect that. But as a clinician, how do you see that as an omission on their part? Or is it because, just tell me what I need, give me the treatment, and let me crack on with life?
John, this is a lovely question. And such an exciting thing to deal with because, what are you going to say to them? Look, I think it's really important you know about X, Y, Z. And that's unlikely to be a good approach to this, okay? But it might be helpful to say, I understand that you don't want to delve into this in any great detail, but perhaps we could talk about those areas that you don't want to know about and unpack it for them, because there will be things that they don't know. And you can simply put them under headings and say, okay, well, so CLL has got all these different aspects to it. There's the infection risks and how to keep yourself healthy and exercise and diet. There's all these vaccines. There are things to look out for. There, you don't want me to tell you about the results of the prognostic markers, but actually that might be really relevant for you. So there's all sorts of biology that you could, so you don't want to talk about the biology. So there are going to be areas for discussion that they say, oh yes, actually, I do want to talk about that. And I do want to talk about this. So what's your experience? Because you get this.
Yes, I mean, some people say, I don't want to know anything, one of which is my best friend in the world. She's very smart, she's very successful, and she shut it down. So, I say to her, if you could just how to make some small inroad. What are you willing to talk about? What would be important to you right now? And then I think over time, it hasn't happened, but we're always hoping that she'll be willing to take in a little bit more. You know, I made sure she got to an excellent doctor because I thought, well, if she's really going to remain this with the blinders on, then we need some way to make sure she's getting good care. And, you know, but I hear people who say, I am not going to anyone except my aunt's breast cancer doctor of 20 years ago. And that's all they're willing to do. So we start. I just view each conversation as an opportunity to sort of move it along a little bit. And hopefully in the right direction, but I don't know. You try.
There might be another element to this as well. So you could say, well, tell me, what are you worried about finding out?
Huh?
What is it that piece of information or question is going to freak you out? What is it you don't want me to tell you that you think I'm going to tell you? So, and then dispelling that, because it's really quite unlikely to be true. My wife always tells me it's always the things we don't worry about that get us. Not
Raymond.
the things we do.
Raymond, I believe you have, I think that's you, Raymond, is it?
Yeah, that's me.
Okay, that was your question?
Yeah, yeah. I mean, I've been hearing this kind of discussion, and certainly what's advocated, one can't disagree with. It would be great, but I've been hearing this at a number of conferences over the years, and when I look at our healthcare system and the way it functions, I don't think it's realistic, and I think we have to think differently about the role of the doctor. I mean, I can understand that as a doctor, you would like to be your patient's coach, support, emotional help. You want to treat the person, and I think that's fantastic, but it's not realistic. Our health system is an industrial system. Our hospitals are industrial type systems where all the tasks are split in vertical silos. You're under intense pressure. The waiting room is full of patients who wait hours. And so I think we need to reach the objective, but we need to reach it a different way. And I think doctors should perhaps focus on where their real expertise is, and we need somebody else filling that role that Jennifer plays, which is that of, I think of it as a coach or a counselor. Or,
I mean, I am a social worker,
yeah.
but we're really required to learn a lot about, well, we cover all blood cancers, but we're really required to know a lot. And I'm perfectly happy to say, you know what? I don't know this, but I need you to go get a piece of paper and write this down, because then it's
That's
a
right.
very targeted, I need to know this Dr. Kennedy question.
That's right.
Yeah.
Versus.
So, but I think we should. I think we will not achieve the goal we would like, which is better supported persons, by advocating that doctors play that role, because it's not going to happen for those. And there's a cultural reason as well, that the whole medical culture. There's all sorts of reasons why it's not going to happen, and why Dr. Kennedy, I believe is your name, is the exception and not the rule.
Yeah, no, your point is very well made, and it lands on its target. I have to challenge it. Okay, I have to challenge it, partly because you could get rid of us as a species. Okay, you could do that.
I'm not advocating that.
But until then, I think we're channeling something with our patients. And the relationship between us exists nonetheless. So we have that relationship already. And the challenge, I think, is how do we realistically develop that relationship of trust and understanding and patient education. And I sit here saying, oh, we have to do this and this and this and this. And suddenly I'm sitting there with my patient, and an hour has gone past and there are still 20 people in the waiting room, and you're saying, you can't do that, okay? But there is a role for that sort of discussion, and if it doesn't happen with me, who is it going to happen with? synthesizing that technical information with prognostic information, with with everything else, because there isn't a model, there isn't somebody or something to replace me. It would be great if they are, but how do we do it? How do we square that economically and efficiently and effectively? I don't necessarily have an answer to that, except that it needs to be broken down into bite-sized chunks. I think we need to recognize that we need to cover a lot of ground with our patients, hence some of this technical stuff about signposting and moving the conversation forward, and yet still making space to listen. That is a real challenge. I don't have an answer for it, but it has to happen somehow. And it's really difficult. There are fundamentals. There is life and death. There is access to drugs, and there is the fact of we have to see lots of people, but we still have to meet those people as individuals. And if we're not, then I cannot, and my colleagues cannot satisfy the needs of human beings, which is to connect fundamentally. And it's not just technical. We do need to do that. Otherwise, I might as well just walk away and go away.
And I think there's a role for the organizations in this room, but they need to be made a place. And I suppose it depends, but the health system where I'm from, there's a wall. And the health system does not reach out to patient groups. I think that's one of our roles. And that's one that we do, but people find us by happenstance.
So I think there is a big team, and that information can be broken down, and it can be delivered in different ways by different people. And I think that what Jennifer does, if I had a Jennifer, I think that would be absolutely wonderful.
Oh, and I'm sure if all the people I spoke to had a Dr. Ben Kennedy, I would be thrilled, because it is really hard to hear that people don't have the information and the time, but I get it. The waiting rooms are full. I truly get it. But even if you do that just once, and then you send them to me, I don't have a list of people waiting to see me. I have a queue. So if it misses me, well, so be it. I talked to someone for an hour. In fact, I talked to many people for an hour, just because that's what they needed in that moment.
Okay.
Well, we could go on, of course, forever. It's such good information, and it's so relevant and so real.
Yeah.
Okay, we're only up against time. That's the only issue, because we have to get our posters done before dinner as well. So that's the issue here. But and they keep sending me rude notes.
So there is something called a Jennifer. There is a thing called a Jennifer. It's called a patient navigator, and they've shown this in breast cancer and lung cancer, where a patient navigator significantly increases the outcomes and the journey of a patient. And we're busy doing work now to understand that those patient navigators don't need to be social workers or nurses, registered nurses, because that puts too much strain and there's not enough. So how can we take peer navigators and patient navigators and lay navigators and help them to help that? And I think that's what the system has to learn, is to integrate that in a spoken wheel place. And that's the role that we as organizations can be played. But until we start to see that the initiation of the conversation and the trust lies with the doctor, but all the fallout from that conversation needs to go somewhere, and it needs to downfall into someone, which is a patient navigation process, because they are far more accessible, they have more time, and they're not as intimidating.
Raymond wants you to set up that immediately for Canada, please. Well, thank you very much, you two. Thank you again for the participation. Very good information. And
All right, there's a good chance.
they'll be around through the rest of the program as well for your questions.